My name is Gina Arnone. I'm 43 years old and I'm from Buffalo, New York. My back pain started about 10 years ago and progressively got worse. The last 3 years was the worst. I run food service. I work in a preschool program. I'm in food service, and all the heavy lifting for the food orders makes my back and legs hurt, and it's just making it hard for me to do my job because of the pain. For my lower back, down my buttocks to my legs, and sometimes it goes around to my stomach because of all the heavy lifting. I found out about NJ Surgical Center through my pain doctor in Buffalo, and he's the one that referred me to come see Dr. Kaul. When I was here Friday for the pre-op, he was comfortable. He made me laugh, made me feel like I was at home. After surgery, I'm hoping to be able to go for long walks, be able to pick up hiking again, maybe go to the fitness center again, just to do all kinds of stuff that I haven't been able to do. It's okay, I'll be walking out of here. I'll be a little slow, but I'll be walking. I can't walk without pain.
The treatment of spinal disorders has evolved significantly over the last 5 to 7 years with the utilization of minimally invasive outpatient techniques for the correction of deformities that would otherwise have required long in-hospital stays. And the patient that we treated in this video had a condition called spondylolisthesis at the L5-S1 level. She had seen a number of surgeons who had indicated that she required an interbody fusion. After a number of discussions with her and a review of her films, I decided that this could be done in a minimally invasive fashion, and it could be done on an outpatient basis. The patient came into the centre the morning of the surgery. She was admitted by the nursing staff at the facility and was interviewed by the anaesthesiologist, who went through her medical problems and the medications that she was taking. She was brought into the holding area where she was seen again by the admitting nurse and the anaesthesiologist, and then from there was brought into the operating room, anaesthetised, and the procedure was commenced. It took approximately 2.5 to 3 hours to perform the surgery, and this was a particularly difficult case because of the degree of slip or the degree of movement of the L5 vertebrae on the S1 vertebrae. We used a posterior minimally invasive approach to decompress the spine from behind, and then to insert the interbody graft with some autograft or iliac crest bone. After we had carried out the interbody decompression and device infusion placement, we then inserted pedicle screws, and again, because of the deranged anatomy, the altered anatomy that she had at the L5-S1 level, we were able to use fluoroscopic guidance to guide these screws in safely. Once the screws were in place, we also used neurological monitoring to make sure that they were within the confines of the pedicles or the bony components of the posterior part of the spine. The procedure took about 2.5 to 3 hours, and the patient was woken up at the end of the procedure. She was taken into the recovery room where she made a very quick recovery. And a large part of the rapid recovery with the minimally invasive approach is related to the fact that there's very little muscle dissection or destruction. We're able to approach the spine in a muscle splitting and muscle sparing approach, and this allows there to be a minimal amount of blood loss, which in this case was approximately 100 cc's, whereas it would normally be anywhere between 1500 to 2 cc's in an open fusion case.
Thank you, thank you, thank you. It feels so, I mean, other than the pain from the surgery, it feels so much better. You know, it's like so much relief off of everything.
Ultimately allowed us to discharge the patient from the facility within a 2-hour post-operative period.
Okay, I need
A little slow.
Okay.
I hope you don't expect me to run a marathon.
Sent home. She was given a prescription for some antibiotics and painkillers and muscle relaxants, and will be followed up in the office in approximately 3 to 4 days' time. There are many advantages to the minimally invasive approach. There are the immediate intraoperative advantages such as minimal blood loss, minimal muscle destruction, a rapid post-operative recovery, but there are also significant advantages in terms of how quickly patients are able to return into the workplace after they've had corrective lumbar fusion surgery. And the minimally invasive approach allows patients to get back to work in a much shorter time frame than if they had their procedure done in a traditional open fashion where there would be a lot of muscle destruction and bony resection.